Okay, Michaela, welcome to the show. For anybody that's never heard of it before, how would you describe DBT in a very basic way?
That's a really challenging question for something that's so complex and rich. But DBT, or Dialectical Behaviour Therapy, is an evidence-based psychological treatment that has been developed primarily for people who have intense emotion dysregulation and who tend to cope with that by engaging in behaviours that regulate the emotion in the short run but cause problems in the long term. So like suicidal behaviours, self-harm, drugs, binging, vomiting, those sorts of things. And it's a treatment that really draws on two sort of really very established traditions. One is behaviorism, which has a long tradition in psychological treatment. And then the other is actually Zen mindfulness, which comes from an even longer, much longer tradition within Eastern culture and practice. And so it's a synthesis, which is where the word dialectical comes in. It draws these two very contrasting things together, because behaviorism is about change, and Zen mindfulness and Zen philosophy is all about acceptance. It draws these two things together to provide a comprehensive treatment for people who have quite complex difficulties. And I think I'm going to stop there, because you said briefly. I'm sure we'll get to unpack some of these things as we talk more.
Yeah, there's a lot in there, and we'll cover that as we move through the interview. But that's a good way to set it up for sure. What would you say the benefits of DBT are as compared with other forms of psychotherapy, like something like, I don't know, maybe like something like CBT or person-centered? What would you say the benefits of DBT are?
Well, I mean, the thing is, any psychological treatment has distinct advantages with particular populations and particular types of difficulties. And it has, CBT has a strong evidence base for some conditions, and Rogerian counselling also is good in some contexts. So the thing is, it's really more about what populations and what contexts is DBT really good for. And DBT has its strongest evidence base for people who often get the label of personality disorder, and so who have a pattern of behaviour that has gone on for several years, and where they really struggle both in terms of their interpersonal relationships and also in terms of their sense of who they are as a person. I'm not a big fan at all of the label of personality disorder. It's extremely stigmatizing. However, that is the label that is often given, and because of the way research is done, that DBT has had most research done with people whose problems are labelled in that way. And so DBT has a really strong evidence base for people who get the label of something called borderline personality disorder, and who also are suicidal and have self-harming behaviours. So that's the group for whom this treatment really works very well. I mean, there are other evidence-based treatments for people who have those problems, and that's important, because no one treatment can be good for everyone. So, mentalization based therapy is a good evidence base for this client group. Also schema focused therapy, which is a branch or a form of cognitive behaviour therapy. So, but the thing that DBT really does well is for people who have a lot of impulsivity and a lot of complex problems. Sometimes it's called comorbidity, where a person has problems that get lots of different labels. So perhaps personality disorder, depression, anxiety, maybe substance misuse. It really is designed to help people who have multiple complex problems, and that's who it works best with, is that group. There has been some work to look at, because of course a treatment like DBT and some of the others I mentioned is actually very complex and quite intensive to offer. And so there's been some investigation into sort of briefer forms of DBT. There is some evidence for sort of less severe difficulties that skills training, which is part of DBT, might be quite effective. But also a very recent randomized study showed that actually 6 months of DBT was just about as effective as 12 months of DBT. And I think as we do more research, we get to understand more what any treatment is good at, and also how you might modify it to try to retain the effectiveness, but not make it so intensive for the person who has to do it. Yeah.
100%. So whenever I was researching for this, it struck me, obviously this is mainly for people with borderline personality disorder and
Yes.
things like that. But it struck me, this is grounded in some really solid and deep philosophy. And I'm just curious, how has, learning this and applying it, and I suppose you've been so immersed in this for so long, how has this benefited you personally, and how might these kind of ideas benefit the average person?
Yeah, I mean, I think that's true. I mean, I think that's true of many of the things that end up in psychological treatments, is that they're of benefit to any of us. I mean, I think it's one of the things I would say about DBT. I think particularly because there's a strong element of it, which is a whole raft of skills. There are sort of like 66 skills in the DBT skills training curriculum. And they're all designed around helping you manage emotions, helping to deal with crises, helping with interpersonal effectiveness. And so there's a real readily applicable element. And DBT as a treatment, it actually asks you to first apply the treatment to yourself before you would try applying it to everyone else. So, you have to practice all of these skills yourself. And so I think it's had a very profound effect on me. In fact, I don't know that I can even conceptualize handling things and coping in my own life without thinking about DBT skills. I think the one strong element is mindfulness. And so that I think has been really helpful. As a person, certainly as a young person, I was quite anxious and had a tendency to always be panicking and thinking about things in the future, and that sort of capacity to just notice that that's where my mind is going and kind of to bring myself back, I think has always been very helpful. But I think the most profound impact on me, although of course now that we're all thinking about the planet and we should all be flying less, it's perhaps less profound than it was at the time, was that I, for most of my early life, was a flight phobic and really disliked flying. I didn't avoid it too much, but because it was necessary for various things, but I really didn't like it at all. And I was quite abjectly terrified whilst flying. But I decided that really that the things that my clients were frightened of and the things that they'd had to put up with and had to deal with in their life were really substantially more, were substantially more than what I had to deal with. And so it really was incumbent upon me to apply the treatment to myself to overcome this particular problem. And so I set about really applying the treatment systematically to myself, and including I even had a DBT colleague, make like a little kind of loop of DBT skills that I could listen to while I was flying, and that I really embraced the whole idea of exposing myself to the fear of flying and really engaging with that and getting rid of all my safety behaviours, but using the framework of DBT to really help that. And yeah, so I mean, it really did transform my life. I mean, I love flying now, but of course now because of the planet, I try not to do it so much, but it really did have a very profound effect of something that I was really abjectly terrified of. The only downside, of course, and I think this is quite interesting actually, because it does reveal something about the treatment, is that, and if anyone's listening to this who's a flight phobic, they'll know that the one thing about being a flight phobic is when you land, there's nothing quite like the ecstasy of landing, because of course you've survived death and you get this absolute rush. And of course, if you cure your flight phobia, you don't get that anymore. So you do have to tolerate a bit of a loss. And I think that taught me something as well about when I'm working with people, is that, we can think about the importance of changing our behaviour and doing new things that are more skillful and more effective and maybe better for us. And sometimes there are unanticipated consequences. And so I always try to think about that, and try to work with people to think about what might they lose by changing their behaviour, and how might we mitigate any downsides of the loss, So yeah, I think the other place that it's really helped me actually is in working with public healthcare systems. I think it can be so easy to feel very burnt out in those systems. And I found the sort of the non-judgmental stance of DBT very helpful, also combined with the sort of the dialectical position that, you know, when you're working in a public healthcare system, there are lots of different layers of the organisation, all which have different requirements, different things that they have to do, different priorities. And sometimes these things can really clash. You know, for example, a system might want to really deliver evidence-based healthcare. And at the same time, they want to keep their waiting lists really low. And, you know, if you have an intensive treatment, that doesn't go so well with keeping waiting lists low. And sometimes this can lead to lots of conflict, and that often is a source of where people feel burnt out. Whereas I think coming at it from a dialectical position, you can start to see that there is merit in both of these different positions, and that everybody's trying to do the best they can with the goals and priorities that they've been given. And how might we together recognize and value those different positions and try to find solutions that respect both sides? And so I think those ideas have really been helpful to me, both in not just obviously in working with people clinically, but also in trying to work with systems and in implementing large projects, particularly where people have different, multiple competing priorities.
100%, 100%. Your example of, you know, landing, whenever you sort of get over your fear of flying and landing, and you don't get the ecstasy anymore, it sort of reminded me of being like 16, 17 and going to nightclubs here in the UK. And whenever you got in, it was the best part of the night, because like you weren't sure if you're going to get in. And then whenever you actually get to 18, all that's taken away, you know.
Yeah, no, right. No, yeah. It's true. Yeah, exactly.
But yeah, so DBT was developed by Marsha Linehan, who I think you actually trained under, is that right?
I did. I mean, you, like many people, I had, you know, she would do these, what she called intensive trainings, where there was a kind of a first week where she taught us intensively. It's called intensive training for a reason, but when she did it, when I trained back in 1994, it was very intensive. You know, we would start at 8:30 in the morning and go till 5, then we'd have a couple of hours off for dinner, and then we'd be back again in the evening for another couple of hours. And so she would teach for the whole week, and really it was kind of pumping in all the information about how to do the treatment. And then we were sent off for a period of time in which we had to get a DBT program up and running, start working with some clients, running some skills classes, and then we'd come back for a second week where we would have to present our work, and she would give us consultation. And so I had the great pleasure to be taught by her back in the early 90s. And also subsequently, one of her graduate students who worked with her much more closely, you know, she had a number of graduate students over the year who worked with her for sort of years at a time. But we were able to get one of her graduate students to come over to the UK, and she, in a way, I continued my training with her to kind of really develop my capacity to do it properly. But yeah, no, I started off with Marsha back in Seattle in 1994. Yeah.
No, she seemed like an incredible individual. Like, not only was she a behaviorist and an academic, she was also a Zen Rushi. Is that right?
Yeah, no, that's right. I mean, she when she started with the treatment, she wasn't a Zen Roshi. I mean, it's a really interesting story how the treatment came to be. She was trained as a behaviorist, and her real passion was to deliver an effective treatment for people who were suicidal. That was her primary aim. And although we didn't know at the time of when she developed the treatment, she subsequently wrote a book and a memoir in which she talked about her own experience of mental health difficulties as a young woman, and how she had really felt very powerfully that what she wanted to do, if she were to get through her own difficulties, which she did, she wanted to develop an effective treatment to help people who were suffering in a similar way. And so that really drove her to, you know, get her education. It wasn't easy for her given the difficulties that she'd had. And so behaviorism was the thing that she really wanted to do. And so she set off applying behavioral therapy to people who were very suicidal. And she selected people who had a lot of suicidal behavior, which was a wise thing to do if you're trying to develop a treatment. And so she selected people who get this label of personality disorder. Now, what she found was that when she tried to apply this behavioural treatment, that did not go so well. In fact, she said, and other people have quoted her as saying, that it blew up when she tried that. That the push for change, when you have such a lot of internal distress in your own life, and there are so many problems that you feel that you need to resolve, it's actually to be pushed constantly for change is actually, it not only is it difficult, but also it feels invalidating, because actually you feel like you don't have the capacity to make those changes. So the people that she was trying to help didn't come back for the treatment, or they found it very difficult. And so she was thinking that she needed to find a sort of complementary way of doing it. I mean, I think initially she actually did go completely to the other side and think, oh, I'll just do acceptance. But of course, if you just do complete acceptance, the problem with that is if you just sit totally with acceptance with people who've got such a lot of pain and so many problems, is that might work a little bit, but then actually the person starts to think, well, actually, if you understood how much pain I was in, you would be doing something about it, or helping me do something about it. And so this is where you kind of get this move. And often therapists, maybe some people listening to this who've not come across DBT but have worked with clients with these sorts of difficulties, might have had this experience themselves, that they've set off trying to help somebody change. That's been too difficult. Clearly the client said, no, it's too much. And they've switched to the other side, but then that's also caused problems. And so Marsha had this experience, but what she decided to do then was to see if she could find a way of bringing these two things together. And so she looked to, like, well, where would I find, who are the people who know about acceptance? Who knows about acceptance? And I mean, she herself had a bit of experience in sort of contemplative practice, more in the Catholic tradition, but also she was very aware of the Buddhist tradition and Zen. And so she pursued that line. She went to Chester Abbey first, and then on to another Zen teacher, and she really focused on developing that side of I mean, I would say her skill set. I'm not sure that's how you would conceptualize it if you're a Zen person, but she worked on really developing her understanding of acceptance. And she decided to come back and try it. And she tells these wonderful stories in her biography of how she set off trying to do, mindfulness practices, which did not go down at all well. And she thought perhaps maybe all this sitting wasn't the thing. So she decided to do mindful walking, and sort of got up and tried to encourage people to do mindful walking, but then when she turned around, there was nobody following her, or maybe one client. So what she realized was that she needed to somehow, and I mean, I think this was part of her genius, really, to be honest, because I think some people would have given up, but I think she really felt that she had found something that was so important that she tried to think, okay, how could I distill these principles, these Zen principles, into a series of skills and practices that I can help my clients to do. And so she really worked on distilling mindfulness in its essence from Zen into a set of skills that you could teach clients, really breaking it down. And she kept taking that back to her own Zen teachers to really get that sort of finalized. And so that was kind of in the early days, but she did continue. So you're right, she did continue with being in the Zen community, and she did become a Roshi herself. So she was later in her career both a professor of psychology, professor of behaviorism, and she was a Zen teacher, a Roshi. So those two things are really very powerful in her own life, and of course are very much represented in the treatment. Yeah.
It's like she has brought together the best of Western philosophy and Eastern philosophy into one modality, which is...
Into one modality. I mean, it's interesting, other people also around that time did similar things shortly thereafter. I mean, Jon Kabat-Zinn, before Marsha, had started to do mindfulness-based stress reduction. And then a little bit afterwards, Mark Williams, Zindel Ziegler, and John Teasdale worked with Jon Kabat-Zinn to bring cognitive therapy and mindfulness together in MBCT. But Marsha was definitely the first to really try and marry behaviorism with mindfulness, and then others have done similar sorts of things subsequently. Yes. And I definitely think she really did try to bring those things together. And I think what was perhaps unique about her, and perhaps is true of other people like Mark Williams and John Teesland and Don Siegel, is that they really have embraced both sides. It's not that they've just, oh, we'll just take a bit of that and bolt it on. They've really tried to embody what it means in mindfulness and try to then really kind of connect it in a really meaningful way. Yeah.
100%. So I want to get into, you know, actually looking at how the therapy works and the best practice and everything. Before we go there, it seems to be that the central problem that DBT tackles is emotional dysregulation, and that might be the thing that is at the root of the problem of borderline personality disorder. So what would you say are the primary causes of emotional dysregulation in people?
Yeah, no, you're very right about that, Neil, that DBT does say that emotion regulation is the central driving force of the problems that get labelled as borderline personality disorder. I mean, theorists from other perspectives on personality disorder would disagree about that, and I think that's legitimate. You know, that there are interesting conversations to be had about that. But DBT does take that view that emotion dysregulation is central, and that emotion dysregulation then drives some of the other problems, such as the interpersonal difficulties, the sense of self dysregulation, the behavioural dysregulation. And of course, if your behaviour is dysregulated, you know, if you're suicidal or alcoholic or whatever, or your interpersonal relationships are causing you difficulty, then of course that's going to feed back into your emotion dysregulation. So those things kind of get tangled out. But conceptually, from a DBT perspective, we would say that emotion dysregulation is kind of at the heart. And DBT has a sort of, it takes the perspective that these problems arise as a result of a transaction between biological vulnerability and what we would call invalidating environments. And so biological vulnerability, essentially, we do know that people who have these sorts of difficulties, there is a degree of this which is heritable. So there is a kind of genetic component. And we also know that people who have these difficulties have a lot of adversity in their lives. And DBT would just simply say that the relative contribution of these two things varies a lot person to person. But I think the key thing is that that these things transact. So it's not just that we have a bit of vulnerability and then you have something unpleasant happen to you and the two things together, okay, now we have these problems. Rather, it's that, you might be a vulnerable person biologically, but what happens to you in utero, in early life, can have a really big effect. So even if, you're perhaps a little sensitive, but if your environment just can't meet your sensitivity needs, then that will exacerbate your sensitivity from a neurological perspective. And although when Marsha proposed her theory, there wasn't a lot of evidence for this. Actually, there is a lot of evidence for this now, that the early childhood adversity can contribute to neurological sensitivity. And then, of course, as you become more sensitive, say as a small baby, you are crying and your parent is depressed and struggles to meet that, you of course then will cry more, which of course will make your parent, who's already struggling, feel even more inadequate and find it even more difficult, and they find it even harder. And then of course that makes you more sensitive. So it transacts in this way over time. And so that means that you can see people who have these problems who might either have kind of been born highly sensitive and had what to other people might not look like major issues happen to them in their life, but there was a mismatch between what they needed and what they were able to get, and that's contributed. Or alternatively, we might see people who actually, if we'd been able to capture it, might actually have not been biologically very vulnerable, but the extent of the trauma and the early adversity actually made their biological system more sensitive. And so it's a transaction in these things over time. And we talk in DBT about these invalidating environments that can really contribute, and they have sort of three characteristics. One is that these environments tend to say, either explicitly or even sort of indirectly, that your personal internal experiences of your emotions, your feelings, your physical state are kind of inaccurate. You shouldn't be having them. There's something wrong with you that you're feeling that way. You know, they sort of signal that you somehow there's something wrong with you if you're having the experience that you're having. You know, so if a child somehow communicates that they're anxious about going to school, maybe they've been bullied or something, but the family environment basically says, oh, you know, you shouldn't be bothered about that, it's not important, or doesn't even attend to the fact that you're having a difficult time, then that's a sort of an invalidation of your inner experiences. The other thing those environments often do is that, because in part, you know, if you have that happen to you, if you're told that that doesn't make sense, you shouldn't be feeling that way, you know, that there's nothing there to help you learn how to manage this problem. And so obviously those feelings intensify, and often the expression will intensify, and then sometimes the environment will respond. And so, of course, then what you've learned is that the only time you get responded to is when your emotions and feelings are very intense and very evident. And I'm not talking here about necessarily about consciously learning that. I mean, that's what happens. Your behavior gets shaped out of your awareness. You know, we're talking about small children here, about how this happens. And so they're not thinking there strategically about, I notice my parent is only responsive to me when I am very dramatic. I mean, they don't have the capacity to think that way. It's just something that is happening in their environment. So that's another problem. And then the third aspect is that these environments often oversimplify how difficult it is to solve life's difficulties, that essentially you get the message that you just got to do better, try harder, and really it shouldn't be that difficult. And so if you're a person who's, you know, had a lot of trauma, got a lot of difficulty in your life, a lot of emotional distress, that message doesn't really help you to cope. And so, but what happens is you end up thinking, well, it's all my fault, it's all my problems, I'm the problem here. And then that just kind of compounds the difficulties. So those would be the sorts of things that we would say would really kind of be the contributing factors. And that, particularly that these things kind of can transact over time. So it's really more a poorness of fit between the person and their environment, and that can take these different forms. It is the case that a lot of people who end up with this label have experienced significant trauma. In some studies, it's between 65 to 70%, but there are a proportion of people who haven't experienced what would traditionally be labeled as trauma, but they've had this experience of chronic invalidation over time. Yeah,
really interesting, and really, I suppose, just sad, you know,
it's terribly sad. It's terribly sad. And the patterns of behavior that people have learned, you know, the way I think about it, when I see a person who comes to me and, you know, they're telling me about these problems that they're having and the problems in their relationships, and also their problems with their relationship with themselves. So in DBT, being a very behaviorist treatment, when we talk about behavior, we're not just talking about external behavior that others see, we're also talking about our internal behaviors, like our thinking and our emotions. That these patterns that the people have learned, that these were really their best effort to cope in extraordinarily difficult circumstances, given what resources that they had. And so the real tragedy is that those things that they develop to try to protect themselves, to try to survive in difficult environments, are just now not working for them. And in fact, they're often ending up being criticized or punished for actually what is their best effort to manage a really set of challenging circumstances. And I think that's the real sadness.
So it was like an adaptive response that has now become maladaptive later on in life. Exactly.
That's exactly right. Yes.
And I suppose that probably links well with things like addiction and stuff too. So you mentioned it there briefly, but in this view, so DBT is a radical, I'm not sure if I'm getting this right, but a radical behaviorist approach.
Yes.
And that means that emotions, thoughts, feelings, all of these things are viewed as behaviors.
Yes.
So why does DBT take this view, and what's the benefit to clinicians of having this view, would you say?
Well, I mean, I think the reason it takes this view, I guess, is because, you know, our founder and those of us who kind of have created the treatment kind of think that this is the most effective way of characterizing behaviors. I mean, I guess talking to DBT therapists, they would vary. Some of them might adopt that approach whilst they're doing the treatment, but they might not adopt it in the rest of their, you know, life. But I think there are some of us who actually kind of think that there is a substantial part of us as human animals that, you know, that we are governed by the environment which prompts our behavior, and then the reinforcers or punishers of that behavior, perhaps a little bit more than we like to think. I think the real advantage of thinking about emotions and thoughts and feelings and sensations as behaviors is that then you can use the principles of behaviorism to treat those things. So, for example, a common problem that people who might have DBT would experience might be hopelessness. Yeah. And we know this is a really, not only is hopelessness extremely unpleasant to experience, but also we know it's a significant risk factor for suicidal behaviours and death by suicide. So it's an important thing to treat. And, you know, many therapists will be thinking about, how do I treat hopelessness? Well, one way to treat hopelessness, which is the way I think, which is a little bit more standard, is to kind of, you know, maybe either challenge the reasons about why the person is hopeless, you know, kind of essentially say, you know, okay, I know things seem bad now, but actually things are going to improve, and, you know, you will feel better, and, you know, these problems that you've got, you will get over them. So sort of challenging the, you know, the kind of I guess the premise of the hopelessness. Yeah. Or some forms might try to suggest that maybe that things may look hopeless, but actually they're not as hopeless as they seem. So kind of challenging, so in some ways challenging the content of the thinking. Now, both of those things are perfectly reasonable things to do and can sometimes be extremely helpful. So I'm not wanting to say that one shouldn't do those or that they're not helpful. What behaviorism would add into that would be more looking at the process. So I would, you know, I might do those other things I've just said, but I would also say, you know, now, when you experience those hopeless thoughts, what do you notice happens next? What happens to your emotions? Do they become more intense or less intense? Do you get any urges, or, you know, when you think those hopeless thoughts? And so then we might think, okay, given that what we'll typically find is that the hopeless thoughts will be fulfilling some kind of function, you know, that they might alleviate some emotions, because it may, you know, the person might feel hopeless and think, okay, I can kill myself, and so therefore they feel relief from their distress. Or it may be that when they think hopeless thoughts, they end up thinking a lot about why they're hopeless and all the things that have gone wrong. But what's happening is that they're no longer thinking about whatever the problem was that set off the hopeless thinking, and so it takes them away from having to solve the problem. So what it helps us do, it just gives us another way of thinking about things, another thing to try, and to, rather than change the content of the hopeless thinking necessarily, but we might bring mindfulness to just noticing, oh, that hopeless thoughts have shown up, and hopeless thoughts are leading me somewhere else. And if I can just notice my hopeless thoughts and just think, is there something else that I could be doing right now, some other kind of activity that I could be doing, or is there a problem I need to solve? It just gives us another way of kind of intervening. I think a particular example might be that with suicidal thinking, sometimes what happens for people with these difficulties, that thinking about suicide can be soothing. It can make them feel relaxed. And so one of the things that you can do, thinking about this simply just as a behavior, is thinking about suicide, then, your emotions you start to feel relaxed, is the therapist can actually do things to change that association or change that consequence, so that in fact, to make sure that the person does not feel relaxed after thinking about suicide, by highlighting what a problem this is really difficult, and kind of changing that association. So it gives you an additional line of treatment by thinking of these things as behaviours rather than getting caught in the content. Another common way we might deal with this, actually, is that you've got me on a bit of a roll here now, thinking about all the different ways it's helpful, but it's quite common for clients to want to give up treatment and say, I want to drop out of this treatment. And what I commonly see is therapists getting a little bit caught in the content about, what the merits of treatment are, whether you should stay or whether you should go. Whereas thinking about this as simply a behaviour, the client has simply said, I want to drop out of treatment. And then, asking, what was going on just before you said that? What happened after that? And then rather than getting into the content, changing the things that go around that, maybe the client's feeling anxious about what they're being asked to do in treatment. So we need to treat the anxiety. It's actually not about leaving treatment at all. It's about the emotion of anxiety. Or maybe they're feeling really sad about lack of progress in the treatment, in which case we need to treat the sadness. So it's not really about leaving treatment. And the thing is, if you get caught in the content, you're kind of missing the point. So kind of trying to see what the clients say, what they're experiencing as a behavior in a sequence, and seeing what the function of that is, can help you really get to the core of the issue, I would say, from my perspective.
That's so interesting. So it's like, you're not just looking at the content, you're looking at the process all around the content and the context. And that is as important, if not more important, than the thing itself. Absolutely.
Absolutely. Yeah. And so I think this is one of the things often people, I think of behaviorism as being somewhat mechanistic. And I think, that there is a kind of that's a valid interpretation. And at the same time, I think it can really lead you to some really central issues around emotion for the person by trying to see what the function of these behaviors is. What's the problem that the person is trying to solve with these behaviors? And that's the thing we want to focus on and help them solve, and find other more effective ways to solve the problem. Yeah.
Very interesting. So we talked there a lot about hopelessness, and from listening to your weekend university talk, the thing that really jumped out at me was when you said that DBT isn't a suicide prevention program, it's a life worth living program. Can you maybe tell us about that and the significance of that philosophy?
Yeah, and I think this really came, I think, from Marsha Linehan's own experience. I think, that's how she entitles her memoir, Life Worth Living, is that I think that, psychological treatments can get a little bit too focused on reducing symptoms. I mean, that's important. And obviously one of the reasons that people come to treatment is that the symptoms they're experiencing are unpleasant. But the thing is, I think what Marsha realizes that just reducing people's symptoms, that isn't the overarching goal. The overarching, and also, especially if you're working with people who are suicidal, her point would be, as is my point, is that, people generally only want to kill themselves if their life is not worth living. That people who have a satisfying life that they are happy with generally don't want to kill themselves. And so in a way, she took the behavior at face value, that's what clients were really experiencing. And so it's really vital that, another kind of core tenet of the treatment is that, that the responsibility of the therapist is to assist the person to get towards the life worth living that they want. And the reason it's especially important is that actually sometimes, in order to do that, you might have to take what we would call like a therapeutic risk, which is that, certainly currently often in services, certainly in the UK, quite rightly, people, we don't want people to die by suicide, and we want to help people move through those crises. But with people who are chronically suicidal, sometimes, unfortunately, what happens is that they end up in systems which become more and more restrictive in order to prevent them from dying by suicide. And of course, that's totally well-meaning. You know, they're trying to prevent that and hope that the person then will feel better and so on. But often what we see is that the more restrictive you become, of course, the less worth living a person's life becomes, and therefore, you know, people still die by suicide in those contexts. And so sometimes in those circumstances, I've worked in inpatient services, you sometimes have to take a little bit of a risk and actually not restrict a person who actually might have strong urges to die in the service of helping them get a life worth living. So you need to stay focused on the goal, and to think about what it, and work with the person and find out, you know, if you often clients will come and say, oh, you know, I say, you know, what are your life worth living goals? And often they've been socialized by services into saying, oh, you know, I want to be less depressed. You know, I don't want to harm myself anymore, or, you know, I want to have better, you know, I want to get on better with my family. And, you know, those are all important things to know about a person. But the question I want to know is, well, you know, if you were less suicidal and if you managed your emotions better and if you got on better with your family, what would you be doing with your life? What would your life look like? And often people haven't thought about that for a long time, if ever. They've often been too afraid to think about it because they've often thought they never would get a life worth living. And so it's a really important thing to start the conversation and start the plans toward. It's unlikely to get a person all the way there. I mean, I guess we could say working on your life worth living is a lifelong goal, but, you know, we sincerely hope in DBT to try to get people more towards the life that they would like to live. And I think it's a really important key part of this treatment is to take people seriously. When people are trying to die by suicide, they are saying something profound about their experience of life. And that's what we want to try and help them to change in the ways they would like to change.
That's, again, very, very interesting. And I love that question that you asked there, just around, you know, if you weren't suicidal, and what would your sort of ideal life look like, or what would it, you know, what would that be? This is maybe a little bit off topic, but I'm just curious, have you found any other questions you've used in therapy to be particularly effective at moving clients? Or if nothing comes to mind here, no worries, but just curious.
Yeah, in terms of life worth living goals. Yeah, I think because often, you know, and some people watching this might be thinking, yeah, but that's all very well, but when I say to my clients, you know, what would a life worth living be, and they say, well, I just want to be dead. And I think one thing to ask in all seriousness, I'm not talking about being flippant, is to ask, you know, for that person, if they were dead, what would that do for them? What do they imagine that would be like? Because that can often give you an indication of what it is that's causing so much pain that the person wants to escape from. I think people are often a bit worried about asking these questions, but actually the data show that actually it's much better just to ask people about these things, talk to them about them, because if you don't, it kind of gives the message that these things can't be discussed and that it really isn't so terrible. And so I find that question a really important one, is sort of, you know, what would being dead do for you? You know, if you were dead, what would that do? So I think that's a really useful question. And then more generally, I don't know if this is really, but maybe this doesn't work in other treatments, but in DBT, a really important question to ask is, when you thought that, or when you had that emotion, what happened next? So it's really into this process of, you know, when a certain experience happened, whether it's a thought, an emotion, or a behavior that you did, or a sensation, what happened next? Because it tells you something about the function of those things. Now that might not work at all in another treatment, you know, but certainly in DBT, that's a good question. What happened next? What did you notice happened next after you had that emotion, that thought? And I guess questions along that line is that I think this is one of the things, it's a hallmark of DBT, it's this behavioural specificity. It really wants to get into the specifics of what was experienced, what was done. And so really kind of, and so as part of that, a really important thing is to distinguish thoughts from emotions, from sensations, because these things have different, they function differently, and how they relate to each other is really important in trying to help a person solve their difficulties. And we're not really helped by the English language, because we tend in English to use the word feeling for all of those. You know, I feel anxious, I feel hopeless, because hopeless is a thought. You know, I feel sick, that's a sensation. But yet the interventions for thoughts are different from the interventions for emotions, and are different to the interventions for sensations. And so the sorts of questions that a DBT therapist really needs to ask is to try and distinguish thoughts from emotions. And when we have, you know, as humans, we have lots of these, what we would call emotion thought aggregates, you know. So you might have a person say, I felt abandoned. Okay. Now, you really want to unpack that, because abandoned would typically be, there'd be an emotion there, probably sadness, but it could be anger. So that would, you'd need to figure that out, or it could be shame, actually, you know, so you'd need to figure that out. There would be some thoughts, you know, typically thought, I have been abandoned, that so-and-so has left me, or, you know, or people are always leaving me. There'd be a series of thoughts about that. And then often there'd be a sensation of some kind that went with that. And that will probably link very closely to the emotion component, but you'd want to know about that too. So as a DBT therapist, you want to get into those specifics, because treating those things requires that you treat the different components separately. I think I've wandered way off your question.
No, that's some very productive wandering. There's so much here we could cover, but obviously the time is limited. But what was I going to say? Oh yeah, so whenever I was sort of learning about this, I was shocked to find you know, whenever I actually found out how this works, you know, how the therapy is actually given, I was like, this is incredible. Like, this is the most ecological approach to therapy I've ever seen. You know, it's very contextual. So maybe I would love to ask you now about the 4 elements of DBT. If you can maybe cover those, I think that would be useful for people.
Yeah. So in terms of how the treatment is structured, and it does really relate to that kind of contextual element. And for now, DBT has been adapted for different settings. And so if you're in an inpatient setting, things might look a little bit different. But in an outpatient setting, DBT has 4 elements. One is a skills group component, and the rationale for this, if we go back to what we were saying about the way in which a person has grown up, is that there are key skills that they didn't learn about how to manage emotions, distress, interpersonal relationships. So that happens in the skills class. And we think about that in behavioural terms as a place where you do skills acquisition, where people learn new skills to deal with issues. Then though, and we all know this from trying to learn new things, you know, if people watching this have tried to learn a language or tried to, you know, play an instrument or play a sport, that just going to a class about it isn't going to be enough. And so in the DBT individual therapy component, what we focus on is really trying to understand the precise controlling variables for the problems. And this is what I think you're meaning by sort of an ecological approach, that we kind of get into the nitty-gritty of the detail of how, for this person, you know, suicidal behaviour, you know, how it comes about and what follows it. We get into that nitty gritty, and then we're really thinking of the things that the person's learned in skills class. How can we tailor that to really solve the different points along this sequence of events, to find a different way to solve the problem that the person's currently solving by maybe suicidal behaviour or some other behaviour that's problematic to them. But also, if you do that, That's all well and good, but learning skills, practicing them, strengthening them in therapy, you know, when you're with a person who hopefully you get on with, who hopefully is warm and validating and supportive, is very different to being out there in your environment and trying these things in the context where actually maybe there are people around who are not very validating and not very supportive, where there are other things happening, other aspects of the situation that are more complex. And so in DBT, we also encourage clients to call us between sessions for coaching in skills, so that they can say, you know, kind of, you know, I know we talked about how I was going to handle my boyfriend last week, but he's just said this to me, and, you know, he's stormed out and I don't know what to do, and, you know, I kind of feel like I can't cope, I feel like my head's exploding, can you help? And then we can work on trying to help with that problem, like in the real, like when it's happening, rather than sort of after the fact. And so for the person in the treatment, they have these three modalities, we would call them: skills, class, individual, and access to the therapist via phone. And then the therapists come to a consultation team meeting, and in that meeting, therapists bring themselves, they put themselves on the agenda and ask for help in solving the problems they are having in delivering the therapy. When you work with people who are in a lot of despair, a lot of distress, and who also have behaviours that put them at risk, that can be quite stressful for therapists. And if therapists are stressed and don't get the right kind of support, they can then sometimes act in ways that are not necessarily as helpful to the client as they might be, because the therapist is too afraid or worried. And so the purpose of the consultation team is for the therapist to be able to take problems that they're having to the team, get the perspective of other people, and that helps them to be more effective. And I think also, just simply, as we said, our clients typically have very complex problems, and any single person is not going to be able to have all of the ideas that could help that person. So it's really like how you can, in a way, your client gets the benefit of the wealth of experience of the consultation team. So there are those four elements which you have in an outpatient DBT program. In DBT for young people, often the parents or the caregivers would come along to the skills class alongside the young person, and they might also have someone else they can call for coaching as well. So how exactly it's done varies a little bit depending on context, but those kind of core elements are central to really any DBT program. Skills, individual to help you with your motivation and to kind of solve your problems, and then some kind of way of generalizing your skills. I mean, if you were doing a program on an inpatient unit, it probably wouldn't be generalization by telephone, but maybe by some people on the unit who knew skills, who would coach you in the moment through it, because they're there. But yeah, so those are the main elements.
Awesome. Okay, so just before we wrap up with those sort of final couple of questions, the other thing I'm sort of really curious to ask about is ActionUrges. And it seems that DBT, a principle in DBT is to help clients go in the opposite direction of action, the action urges that follow emotions. Can you tell us about that and why that matters?
Yeah. So the DBT, like many other cognitive behavioral treatments, talks about how emotions are structured. And, you know, emotions have many different components. You know, there's a kind of a thought kind of element, but there's also the sort of internal experiences. You know, emotions change our physiology, you know, they change the chemicals in our brain, the muscle tension in different parts of our body, how we sense them, and so on. And then they also have the external things that other people can see, you know, the actions that we do, the facial expressions that we have. And I think people listening to this will be very familiar with the idea that in anxiety treatment, for example, we know a common action urge, if you're anxious about something, is to avoid, like me wanting to avoid going on planes. I remember when I was going to my first DBT intensive with my colleague from the adolescent unit, we were walking to the gate, and my colleague said to me, because I was a flight phobic, remember, he said, "Why are you slowing down?" And I wasn't even aware of it. But, you know, my action urge was not to go to the plane, it was to run. So we're very familiar with that with fear, but it's actually true for other emotions too. So sadness drives us to want to hide away and withdraw. Anger drives us to want to attack. Shame makes us want to hide away. So action urges drive us to act in accordance with the emotion. And, if you think about the fear example, we know that if you continue to avoid things you're afraid of, over time your fear goes up. And it's the same with other things. So that one way to get an emotion to go down, assuming you want it to go down, is to act opposite to the action urge of the emotion. Yeah. So if you're really angry at something, and actually, now anger, of course, is a very useful emotion, but sometimes you have it, it's too intense, it's getting in your way, that you want to go opposite to all of the urges. So, you might want to, kind of stand up close to the person you're angry with, you furrow your brow and you maybe clench your fists. And if you want your anger to go down, this is not going to happen if you do this. So you need to sit back, you need to let go, you need to change your facial expression. You also need to deal with any thoughts that you're having, which are angry. You need to go opposite to the action of thought. And then you will find that the emotion will come down. But I think one thing I do just want to say is it's important to remember that sometimes we don't actually want the emotion to go down, because sometimes the emotion is telling you something important. And so in order to decide whether or not you need to act opposite to the emotion, or in fact something, or rather actually act with the action urge, you need to think about whether the emotion itself or its intensity is warranted in the current circumstances. So if someone is criticizing you in public, and this is, any of us would feel angry in this situation, you need just enough anger to actually tell them firmly to stop. You don't need so much that you want, if you're going to hit them, this probably would not work well for you, but you need enough to be able to actually stop the behavior, or to, whereas if you don't have sufficient, and just kind of say, oh yeah, no, it's all my fault, I shouldn't have, no, I'm at fault, that's not going to do well for you in the long run. So one of the things, the arts in DBT, is to really work with a person to figure out how much of the emotion is warranted by the situation that they're in, how much of it do they want to keep, how much would fit with their values, and then you can work on acting opposite to get down to that bit, and then you can help them work on experiencing the emotion which is warranted. And this is sometimes really important. Some of the clients that we see, because of the invalidating environment, sometimes they need to upregulate their emotion. They could do with more of it. I can think of a client of mine who discovered that her flatmate was stealing from her. And when I asked her about it, she did not feel angry about it at all. She felt like she probably deserved to be exploited. And so we had to work actually on upregulating a bit of anger. Now, not so much that she started attacking her flatmate, because that wouldn't have been helpful either, but she needed to have sufficient anger to be motivated to solve this problem. So I think sometimes this can be a problem that therapists can get a little bit caught on, and they spend all their time trying to regulate emotion away, failing to recognize that emotion often tells you something important and often really is needed to get you to do certain things. So yeah, and when we get to the books that you wanted to recommend, one of them really tackles that problem in a really excellent way. For therapists from any persuasion who are interested in knowing a little bit more about this. Yeah.
Brilliant. Well, you've just set it up, so now you've got to tell us the 3 books that you recommend every therapist should read. Every
therapist should read. Okay, so I think every therapist should read Regulating Emotion the DBT Way by Christine Dunkley. That's published by Routledge. And as I said, this book really covers all of the emotion, all of the main families of emotions, and how you might regulate them down if that's what the client needs, or how you might upregulate them or experience them if that's what the client needs. And I think also for any therapist, it'll just get you more specific about the emotional vocabulary that you can use, and then help your client to do the same. I think if you're interested in knowing more about DBT, just in terms of, for example, being able to orient clients or to direct them, then, I would recommend the small book I wrote with Heidi Hurd called Distinctive Features of DBT. And then for people who are really interested, obviously, in doing the treatment, I mean, there is no substitute for reading the treatment manuals, but they are not an entry-level read, if you like. You know, if you wanted to get a flavour for what doing DBT is like in a more sort of much shorter way, then there's a lovely book by Kelly Kerner called How to Do DBT. And that's a much more accessible entry level kind of book about what it would be like to do DBT, which I think would then, you know, then if someone wanted to go on to learn the thing, they'd have to obviously read the whole manual. I mean, I think, I know you said only 3, and so I'm way over, but I think for anyone who's interested, just more generally, that they might find Marsha Linehan's memoir of interest, because she talks about the treatment there in a more conversational way, and also how it linked to her own life experience. And so that's quite an interesting read, I think, for any therapist.
I think that's a great shout, that last one, because I think whenever you are able to link theory to real life examples, yes, especially from someone who developed it, you're going to learn it a lot better, you know. Yeah. And for anybody that wants to, maybe after listening to this, maybe they're really interested in, you know, training in DBT or going down that path, what's the first steps that they can take, would you say?
Well, I mean, I think there are lots of places where you can get like a 2-day workshop, which would introduce you. Often what we suggest is that people start with the skills, to learn and understand the skills, and those are useful to therapists from any background. And there are lots of places, if you go online, you can find 2-day skills workshops, which will give you a good grounding in the skills. If you're wanting to learn how to deliver the treatment properly, you'll then need to do much more extensive training. And actually, many of the treatment providers who do this do it very similar. Training providers do it in a similar way to the way Marsha Linehan did with me, is that, you know, you'll have, you know, 5 days of sort of intensive learning, and then some tasks to do, and then a follow-up period. So the sort of intermediate training is typically around about 10 days. I mean, different training providers do it differently, but it's around about 10 days. But then it's like any psychological therapy, you would need supervision really to get to be able to, you know, become a seasoned practitioner in the treatment. Yeah. So, but definitely start with the skills, because wherever you know, whatever training, whatever therapy you do, knowing those skills can be useful and helpful. And also that would give you enough of a flavour of the treatment to know if you wanted to go on to do more, or whether skills was quite enough. Yeah.
Awesome. Okay. Well, Michaela, that's really all we've got time for. Before you go, I just want to say, you know, I've been blown away by 2 things here in preparing for this interview. Just first is DBT itself. Like, I didn't know that much about it, but I'm shocked by just the depth and richness of this approach. And then also just yourself as an ambassador for the approach. You're doing such a great job, and the amount of, if anybody's got time and they want to do a follow-up, Michaela did a 2-hour talk with the Weekend University, and just the amount of depth and knowledge and everything that you're sharing is outstanding. So I just want to commend you on that, and just keep it going. And
thank you very much, Neil. Thank you very much for the opportunity to share DBT with a wider audience. Much appreciated.
It's my pleasure. Anyway, I'll let you go, Michaela. Thanks so much, and talk to you soon. All right.
All right. Thank you. Bye-bye.